What is the Maternity Dashboard? The Maternity Dashboard is a tool that can be employed to monitor the implementation of principles of clinical governance on the ground. It can be used to benchmark activity and monitor performance against the standards agreed locally for the maternity unit on a monthly basis. It follows the principles of a car dashboard, which provides contemporary information about the amount of fuel in the tank, speed, state of the battery, temperature of the engine, so that appropriate action can be taken before the car breaks down, for example, refueling when the fuel gauge is on low rather than stalling on the motorway with an empty fuel tank. Similarly, the Maternity Dashboard will provide contemporary information about resources, clinical activity, risk management issues, user views and so on, thus enabling early identification of deviation from agreed goals and initiating a timely and appropriate action to be taken to avoid patient safety incidents and to improve clinical care. Individual maternity units should set local goals for each of the parameters monitored, as well as upper and lower thresholds. A suggested approach is to use the traffic light system, such as green, when the goals are met, that is, within the lower threshold, amber, when the goals are not met, that is, above the lower threshold but still within the upper threshold. If a parameter is in amber, it indicates that action is needed if one is to avoid entering the red zone, red, when the upper threshold is breached. If a parameter enters the red zone, then immediate action is needed from the highest level to maintain safety and to restore quality. The Maternity Dashboard was first tested in a maternity unit after it got into difficulty, and it proved to be an effective tool in preventing further problems. It is now being used in several hospitals and in several disciplines, and the one used in St George's Healthcare NHS Trust, London, is attached Appendix 1. It is important to appreciate that the Maternity Dashboard goals described in this template can be modified to suit the needs of individual units. What parameters should be included in the Maternity Dashboard? The primary objective of using a maternity dashboard is to monitor various aspects of clinical governance contemporaneously, so corrective action can be taken when there is deviation from expected performance. Broadly, 4 categories are suggested: clinical activity, workforce, clinical outcomes, risk incidents, complaints or patient satisfaction surveys. Clinical activity. The clinical activity parameters to be monitored in a high-risk consultant-led unit could include the number of antenatal bookings each month, number of deliveries, cesarean section rate, instrumental vaginal delivery rate, and so on. In a low-risk midwifery-led unit, these could include the number of deliveries, number of women transferred in labor, water birth and home birth rates. The number of times a unit had to be closed for admissions due to shortage of beds because of increased patient numbers or inadequacy of staff needs to be monitored to prevent recurrence, which will increase patient dissatisfaction and compromise patient safety. Workforce. The midwifery and obstetric staffing levels should be monitored, including staff sickness levels and the use of agency bank staff. Attendance to mandatory education and training days could also be monitored to ascertain compliance with the Clinical Negligence Scheme for Trusts (CNST) requirements. The midwives to deliveries ratio, as well as the midwifery supervisors to midwives ratios recorded whole-time equivalent (WT) would provide the adequacy of midwifery staff and their supervision. This needs to be kept under vigilance to alert management to employ optimal number of staff to deal with any increase in the number of deliveries to ensure a high quality and safe service. The number of hours of prospective consultant presence should be recorded and monitored in accordance with the safer childbirth recommendations. Clinical outcome indicators. Specific clinical outcome parameters like eclampsia, major obstetric hemorrhage, blood loss over 2,500 milliliters, massive blood transfusion more than 4 units of blood, admission to intensive care unit, Erb's palsy secondary to shoulder dystocia, failed instrumental delivery rate and 3rd and 4th degree perineal tears, could be monitored to understand the magnitude of a clinical problem, the adequacy of management, and importantly to help the unit plan for resources, training and review of guidelines. Neonatal morbidity of meconium aspiration syndrome, hypoxic ischemic encephalopathy. High and unexpected admissions to the special care unit should be monitored to identify and rectify lapses in intrapartum care due to avoidable factors. 4. For risk incidents complaints and patient satisfaction surveys, patient complaints and user feedback from specific areas in the maternity service, antenatal clinic, labor ward, antenatal and postnatal wards, as well as the community could be monitored to ensure a responsive, patient-centered care. Information collected by risk management midwives can also be included in the dashboard pro forma. Determining the traffic light threshold values green, amber, and red. There are various sources for deriving targets, such as the COG and the National Institute for Health and Clinical the Excellence Guidelines, confidential inquiries into maternal deaths and maternal morbidity data reported in the, for example, the 3rd and 4th degree tiers in the annual report of the Scottish Programme of the Near Miss Survey. The incidence threshold could be set at less than 5, based on the COG guidelines for management of 3rd and 5th degree perineal tiers. 5 midwifery staffing ratio could be considered as 1:30 WTE, 1 woman, as in the recommendation for safer childbirth. 4. Local targets can also be developed, based on the Healthcare Commission's according to recently published data. Comparable best outcome data for various sized maternity units are available. As a tertiary referral center serving a high-risk, diverse population, the incidence of obstetric, the rate of major obstetric hemorrhage has been set at a slightly higher than average. The local targets can be set by looking at the best performing trusts. Similarly, the maternity dashboard shown helped the unit to identify an increase in the 3rd degree perineal tiers red, which enabled the unit to provide training and support to the individuals concerned. Corporate governance arrangements. It is important for each unit to modify the maternity dashboard card to reflect complexity of their clinical workload, unit size, workforce requirements, consumer issues and clinical outcome indicators. A quarterly report should be produced by the lead clinician of the labor ward to highlight issues of concern that require management input of the directorate team to find appropriate solutions. The overall aim of developing such a reporting mechanism would be to ensure that a continuous quality improvement system is put in place to support the safe delivery of obstetric services. This can only be achieved if this regular reporting process is embedded in the Directorate and Trust Clinical Governance Report, thus ensuring an appropriate strategy for action,